Good morning or evening or night, depending on when you're watching this video. It's Josh, your friendly local trauma program manager, bringing you a quick little review on venous access and intraosseous access. So, of course, whenever we're thinking about our unstable patients, we're always going to try to get an IV because, of course, it's the preferred method. It's a little bit nicer for our patients, and we're all really comfortable with it. So whenever we're thinking about that critical patient, we want to make sure that we do 2 quick attempts. 90 seconds is what we're aiming for in order to get that in. Remember that a bigger gauge is not always better, and choose the size based upon your patient. Remember that our rapid infusers work better with a larger gauge, but that does not mean that you need a 14 or a 16 gauge in. But what it does mean is that if you have a 22 gauge patient in your patient, that a rapid infuser won't work too awfully well. So try to get at least an 18 if you're thinking that you're going to be using the rapid infuser. Intraosseous is a great method of securing access in an emergency. We want to be aggressive with using it, but also we want to be really diligent in our technique so we don't cause any harm to our patients. So just a nice little slide here looking at the flow rates, comparing peripheral IVs to IOs. We can see that that 15 gauge in the tibia will flow about 30 mLs per minute, and it takes about a half an hour to get 1 liter of fluid in. The humeral IO, which we'll talk about, doubles that, cuts that down to about 17. Remember that we cannot hook up a rapid infuser to an IO, so that's why our IV is preferable, but worst comes to worst, we need to get that IO in quick. Back in 1922, Dr. Drinker was the first physician to describe the interosseous cavity as being someplace that you could place a device and provide fluids to a patient. Found that it really worked well for patients that were difficult to get IV access in. And then it kind of went away because there wasn't really good equipment out there until the 1980s, whenever we finally got ourselves some modern, quote unquote modern, like Jamshidi catheters that allowed us to access that space. And that's whenever it really came back into pediatrics. And we'll talk about when it was first pushed into PALS. So in 1988, it was first endorsed by PALS as the first choice access for a patient in cardiac arrest. So not messing around with anything else, going straight to IO. It continues to evolve. It's being used on a lot more patients than it ever has been. There's a lot of different devices out there, but of course it still takes some skill. So how does this actually work? So that we can see whenever we take a look here that we are going to have the interosseous device, which is going to go into the cancellous bone, which is that spongy bone that we have in the middle of our long bones. And then we have these Vericin canals and the Volkmann canal. And that allows any of that fluid within this space to get out of the collateral circulation and get into our arteries and our veins. So there's several different IO devices out there. Some are a little bit more common than not. Of course, we'll talk about those as we go through, and just be familiar what we're using come in. So the Jamshidi, or the Illinois bone marrow needle, of course, that's a non-powered device. They do make it in a couple of different sizes. The 15 gauge is the one used for older kids and adults, and then you have an 18 gauge used for neonates. The 18 gauge is a little bit smaller in its depth as well. Reliable, the battery doesn't go out of it unless your hand breaks, I guess. Remember that you can adjust the depth on these, and that's going to be by twisting this barrel here. You can twist it counterclockwise, and it'll actually decrease the depth of your needle if you're putting it in a smaller patient. Gives you really good tactile feedback, but the bad thing is that if it slips off of your target space, it's easy to bend the shaft of that needle, especially whenever we're talking about that 18 gauge catheter. The Neo, we actually got some trainers of these, so I'm going to be showing them off in the near future, just as something we might start to see, maybe not at our hospital, but coming in from EMS or an outside hospital. It's a spring-loaded device. They do have a infant version, which is the pink one here. The thing about it is that this needle is kind of graduated or stepped off, so it has an 18 gauge and then a 15 gauge catheter over top of it, and supposedly, I don't know if this is true, allows for a little bit better tactile feedback as you're breaking into that cortex. They have a pediatric version, which is the red version here. It's used for patients between 3 and 12 years of age, and it actually adjusts up and down to give you different depths of needle length based on the patient's age. SAM is the company that makes those orange SAM splints that we see sometimes come in and the ones that are being used in the urgent care. These are manually driven IO drills. So whenever you squeeze the trigger on this, it causes a big corkscrew action and will drill in your IO needles without the need of a battery. So really nice for like a tactical kit because you never have to worry about the battery being dead. The nice thing is that it uses the exact same coloring and sizing scheme as the EZ-IO, which is what most people are familiar with. And then it does come with this little adapter right here that'll allow you to use EZ-IO needles with this manual driver. So kind of a cool thing. Of course, the ones that we use here in the hospital and we're most familiar with because it is kind of become the standard is the EZ-IO system by Teleflex. Remember, it is battery driven, so we have to make sure that we actually check the battery on them. It has a green light at the back of the palm here that should light up green. Actually, ooh, let me change that to green. Whoa, whoa, green light right there. Should light up if the battery is sufficiently charged, but you'll find that if you place your hand over the device and squeeze the trigger, it actually ablates that green light. And that's really supposedly a feature because if you are doing it under tactical medicine and you're out in a wartime area, if that light lights up, it might give away your position. And so that's why whenever you place your hand over it, you can't see the light. But again, it makes it difficult to actually check to see if the battery is charged. Remember, it comes in those 3 different needle lengths, which we'll speak about in a minute. We'll talk about the super fancy stabilizer device. And of course, this has become the Kleenex of facial tissue. It's what people think of whenever they consider a patient has an IO device in. So what are going to be the sites that we can use for any of these IO devices? The first sites that we usually think about is the traditional spots in the tibia. So for the proximal tibia, we can see where our location is. So medially, just below that tibial tuberosity, we can see the distal tibia site, which is going to be on the lateral aspect. And then for little bitty kids, we can see that it's going to be pretty small place to hit. And that's why we really recommend that distal femur that Dr. Laffey is so whenever we're thinking about that tiny little tibia bone in a newborn or a small infant, going to be a small location to hit. So thinking about the distal femur. So whenever we do place that, we need to make sure that we go a little bit medially because we want to avoid, there's a tendon that'll run down the center here. And so going off to one side is going to make it better for our patient, avoids any damage to that. And then remember, after you do your insertion, we need to make sure that we keep that extremity straight so that they don't actually flex it and cause the catheter to come out. So let's take a look at that distal femur placement. There is no audio for this. We're palpating and finding our location, keeping that leg straight, not allowing it to bend. We can see our target location described. So whenever we are doing the distal femur, it may be advantageous to use the blue IO even in a small patient, such as a neonate or a very young infant. Remember that once you insert it and you feel any resistance change whatsoever, you are most likely in, and you do not need to keep drilling until you actually seat it into with the edge of the needle up to the skin. And that's why we're going to use that stabilizer that actually telescopes up and will encompass that without going all the way down to the skin. We're going to talk more about sizing in just a moment. So as we place that stabilizer on, it will actually telescope up and accommodate, like I said, if you're not flush with the skin. Remember to always use that extension set. Secure it well. Flush, whenever we flush, we're looking, hopefully we'll get some pinkish, yellowish return, but you don't always have to have that. Whenever we flush, though, we need to make sure that we flush an adequate amount. We need to make sure that we feel for any sort of extremity getting cold or tight, because we want to make sure that our fluid is actually getting into the space that it needs to be in. Okay, so what are we thinking about if we're putting an IO into the lower extremities, especially our trauma patients? We need to make sure that they have a stable pelvis, because remember all the vasculature that runs through your pelvis, and so they call it the circle of death. And so if you're putting IOs in the lower extremities and you've got a pelvic fracture that have caused a vessel to be injured, it may not get into the central circulation. So check your pelvis first. Talking about placing an IO into the proximal humerus. We can use this if there's lower extremity trauma. We see a lot of it in adult cardiac arrest, so EMS has become pretty familiar with doing it, so they're translating that over into kids as well. Does give you a higher or faster rate, so you can get a larger volume more quickly. It can be used on kids that don't fit on the Broslow. So we're thinking about our adolescent kids. This is where it's going to be most useful. And apparently it's reported to be actually less painful than a tibial IO. So this is going to be going into the humeral head. And so we need to have our patient either sitting up or lying flat. We want to place their hand across their stomach, and that's going to really bring that in to the place that it needs to be, so it actually gives us our landmarks. We place that palm on our patient's shoulder, and you should really feel that ball, which is the humeral head, kind of sitting on the T, which is going to be the surgical neck of the humerus. Now we need you to karate chop your patient. So one hand goes on that ulnar aspect. The second hand is going to go on the opposite side, karate chopping them, and then together and kind of run them up, still palpating for that surgical neck, for that ball on T sort of thing. And then once we feel that, that's going to be our insertion site, about 1 centimeter or 2 above that surgical neck. We can see it in, let's see, get my green up here again. We can see X marks the spot. We can see where we're actually going to place our IO. Again, another great picture. Going to just be aiming for that golf ball sitting on top of there at about a 45-degree angle, aiming towards the infralateral border of the scapula. Yes. Notice on these that anytime we're drilling a humeral IO, we're always using, let me switch to yellow, we're always using the yellow IO, because that's going to be the only one, the 45 millimeter one, that has the right depth for us. Of course, place your stabilizer, do your thing, just like we talked about in the earlier slide. We'll practice that on. So is there any real official training from any of these manufacturers? Not really. We really need to make sure that we make each attempt as realistic as possible. The things that we have are the Sawbones, which make a lot of great orthopedic training things, and they make a pretty excellent skin model and then bone model, and then it has that cancellous bone there, and so it feels pretty good. We want to make sure that we encourage good technique, and one of the things we realized with the outreach education team is that we were always using these pink needles to go in there because we didn't want them to go through and mess up the countertop that we were teaching on. But what it was doing was reinforcing that for kids you should always use the pink, when most of the time if you're not a neonate or a very small infant, you need to be using that blue size needle. So we switched out to those. Hopefully we're going to see less people missing the bone and not actually providing a good, solid, secure IO by training with the blues. So some pointers for this, especially using the Easy IO system, is let the drill do the work. I always say consider you're using one of these giant power tool hammer drills to repair your grandma's fine antiques, and so you want to be as careful as possible so that you're actually letting the machine do the work for you. Make sure that you always identify your landmark first. Take a couple extra seconds to make sure you're actually doing it in the right location, because that will lead to increased success. And then whenever we're putting that IO through the skin, remember that we need to put it through the skin, touch the bone, and take a look at the black lines that are on the needles that we're going to talk about in the next slide before we ever pull the trigger. And that's going to make sure that we actually have enough depth and we can be successful. So pink, blue, maybe even yellow, what is the best size that I need to use for my kid? So if we take a look at these, the way that they have them sized is kind of goofy. And unfortunately, they submitted all this stuff with their packaging to the FDA, and it's really hard for them to change it. But if we take a look at it, the pink needle, which is the one I said, neonates, very small infants, is only 15 millimeters long. And they say that it goes from, on here, 3 to 39 kilos. The blue one is 25 millimeters long, and it says 3 kilos and over. And then the yellow is 45 millimeters in length and is 40 kilos and over. So, I mean, pink is really for newborns and infants. And have you guys ever seen a 39 kilo infant? I know I haven't, but maybe somebody has. And so if we can get into our minds that we really need to be using the blue most often on our pediatric patients that come in, we're going to have greater success. EasyIO put out an 89-page guide, which I'm sure each one of you have read because it comes on the internet and will tell you everything you need to know about it. Yeah, nobody reads 89 pages of literature about a product that they're using. But if you dig through it, it actually will give you this info. It says that 15 millimeter one is really good, which the 15 millimeter one, again, remember, is our pink, is good for proximal and distal tibia insertion in neonates and small infants. The 25 millimeter one needs to be done on the distal femur in neonates and small infants, or the humerus or the femur, or everybody else in children. So pink, little bitty babies in the tibia, blue, all other kids, okay? Use the yellow if we're talking about using them for the humeral IO. With that being said, 15, 25, and 45 is just the length. They are all 15, a 15 gauge needle, just in case you have a jeopardy. So here we are talking all about the depth, right? So they're using a yellow needle to illustrate this here. We're going to place it all the way through and touch the bone. You see this black line? Each black line is 5 millimeters in graduation. We need to make sure that we have at least 5 millimeters because that allows us to pierce through and get into the cortex with that cancellous bone. So have to be able to see one black line. It applies to all sizes. Remember that your stabilizer will telescope. So let's say that this was properly placed and into the cancellous bone. Remember that stabilizer will go over top of this and will encapsulate it without having to have that hub down to the skin. So how do we know we're in? So remember that kids' bones don't give that same pop as an adult bone. So if you feel any sort of resistance change whatsoever, change in the sound of the drill, if it just feels like something's a little bit different, go ahead and stop. You're most likely in. We need to flush it with plenty of fluid. If you take a look at the official documentation, it says for kids to do 2 or 3 milliliters, but Dr. Laffey will recommend 10 to 15 mils, even in little kids, because we're really trying to make sure that this is going to be a patent IO, because we don't want to have a chance of getting either normal saline or medications out into the space outside of the IO, because that can lead to some really bad effects that we're going to talk about in a moment. And remember that whenever we're flushing this, it should not take a lot of pressure. It should flush easily, but a little bit more stiffly than if you're flushing an IO. So why is this so important? Because of course, if you don't get the meds into the right space, they can't do anything for us in our PALS algorithms, but we also have a couple of different injuries. So up here, the top picture that I'm showing, this is actually going to be an epinephrine injury. So this was a case out of the Ukraine. They had a patient that presented in cardiac arrest. They placed an IO. I think it was actually an emergency physician that actually works on the ambulance there. They gave 2 doses of epi and a little bit of fluid, and within an hour or so of arrival to the hospital, we started to see this incredible injury. They were at a pediatric hospital that had surgery, and so they went ahead and did a fasciotomy on it, but ended up a couple of weeks later, they discharged the kid home neurologically intact, but he had to have an above-the-knee amputation because the epinephrine got out of the IO space. And then the other thing that we see is friction burns, and this comes with using too much force and pressing too hard on the IO gun, and then also allowing it to spin longer than it needs to. And so this is actually the hub of that needle getting on the skin and spinning and causing a dermal abrasion and burning. We've had a couple of kids come in by EMS and from outside hospitals that have had this injury, and they actually have to have a referral to plastics for it. I know that I was reading an EMS report a couple of months ago. There was a fantastic documentation of placing an IO in a child. It actually used to be one of our transport team members that now just works in the 911 service. And he actually mentioned seeing the old scar in the opposite leg from an IO and how he placed it in the other leg. At first he started off with the pink. He realized he couldn't see any black lines, so he swapped it out to a blue and then showed his successful cannulation of that IO. So a really good job documenting and also reducing the chance of injury. Pain relief, yeah, IOs hurt, but it hurts worse if you're dead, I think. So what can we use? So we can use the regular cardiac lidocaine, the kind that comes in the red pinkish box. So that's that 2% lidocaine. For adults or our full-size kids, they're usually going to get 40 milligrams. And then for infants, they're going to get 0.5 milligrams per kilo up to that 40 milligrams max. And then it comes down to technique, right? So the first thing we're going to do is flush that extension set with the medication dose of lidocaine we want to give. We want to slowly push that in over 2 minutes, also known as 120 seconds. Then we're going to let it dwell / chill, right? Hang out. The next thing we're going to do is put a rapid flush. So we're trying to bust open that space so that we have a place for our medication and our fluids to get to. And then we really need to follow up with half the initial dose, again, slowly over 60 seconds. And that's going to provide some excellent pain relief to our patient and make them feel much more comfortable if we're needing to do an IO while they're awake. So some tidbits and takeaways, right? So can you put 2 IOs in the same bone? Nope, sure can't. Only 1 attempt per bone in 48 hours, so make sure you're on your landmark. Do we need to keep flushing this thing to maintain its patency? Sure do. If we give it less than 30 mils per hour, it's probably going to clot, and so we need to have at least 30 mils per hour as our maintenance, or if that is too much based upon the size of your patient, just make sure that you're doing something to maintain the patency. What about growth plate injuries? We're worried about that. We're a pediatric hospital. Guess what? It's possible, but there have been no documented cases of an IO being placed and having a growth plate injury. But if we're concerned about it, refer them upstairs to Dr. Engel's group. Air embolism, yep, same thing. Just like we're talking about with an IV, we can get an air embolism. Same thing with an IO because it does get into the same vasculature. So make sure you're always using a primed extension set. Other things, let's see here. 45 millimeter, so remember that's the yellow one. Can we use those in a pediatric patient? Remember, they aren't defined by the patient's age. It's all based upon the patient's size and what length is needed. And so if you're going to be doing a humeral IO in a larger child, you will need to use that yellow 45 millimeter needle. So always use the right size based on the patient's size. Burn patients, can we use them on them? Absolutely. It can go through burn tissue as long as the bone below it, so like a really bad 3rd degree or the mythical 4th degree burn, isn't there causing actually injury or charring to that bone, you can place an IO if you need to through the burn tissue. Of course, if you have another location, great, but don't think just because they're burned you can't use this great device. CT scan, yep, works just as good as an IV. So there's quite a few case reports that show they can even do contrast and angio and that sort of thing with it. So what can we give through it? Pretty much everything. So TXA has been given. Of course, we can give blood. There's a really good pediatric study that shows that you can actually do your RSI drugs through IO. Takes a little bit longer to work, like a couple of extra seconds, but it will work just fine. You can give your stuff for brain injury. Clotting factor is kind of a cool one. We actually discovered that one here. Dr. Putz upstairs in the bleeding disorder clinic actually wrote a paper on this. We were teaching some local EMS folks how to give clotting factor in the field, and one of them asked the nurse, Lydia, hey, can you give clotting factor through an IO? Well, she had no clue what an IO is because that's not her world. So they got some information on it. They looked it up. Sure enough, they said, nobody's ever done it, but we don't see why it wouldn't work. They had a patient a couple of months later who had an undiagnosed bleeding disorder, got circed and wouldn't stop bleeding, and they tried forever to get an IV, and finally they popped an IO in this newborn and gave clotting factor, and it worked. So Cardinal Glennon was the first people to use clotting factor through IO. So yes. So remember, pretty much everything that can go through an IV has gone through an IO at some point. So every PALS medication, ACLS medication, like pretty much everything can go through an IO because it ends up in the same space.